All right, welcome everyone to the UC Berkeley School of Public Health Research Brown Bag. I'm Jen Ahern, Associate Dean for Research, and I'm really excited about the talk today. I still have quite a lot of interest and participation. I see the participants growing on the Zoom, and we have two speakers today who will give a collaborative talk on the really important issue of how COVID-19 has been affecting people who are in the prisons in the U.S. Our first presenter will be Dr. Brie Williams, who's Professor of Medicine at UC San Francisco, and she's the founding director of the UC Criminal Justice and Health Consortium. And our second speaker is Dr. Steph Bertozzi, who you will all know, our Dean Emeritus and also Professor of Health Policy and Management here at the Berkeley School of Public Health. So welcome to both Brie and Steph, and I'll let you take it away from here.
Wonderful, thanks so much. And thank you all for coming and joining us today as we talk about our collaborative work in this area. We're going to speak again about prison health during COVID-19 and some of the lessons we've learned. First, I want to introduce you to my program, which is called Amend at UCSF, which draws on public health, human rights, and Norwegian correctional practices to transform U.S. prisons to focus on the dignity, humanity, and health of residents and staff alike. And during the COVID-19 pandemic, Amend has been laser focused on lending our expertise as healthcare professionals to correctional systems really around the nation, and especially in California, to try to improve their response to the pandemic. And early on in the course of the pandemic, we partnered with David Sears at UCSF from infectious disease, and then with UC Berkeley's Stefano Bertozzi and Sandra McCoy to create the COVID in California Prisons Project, really to advise California's Department of Corrections and their healthcare work on COVID-19 related matters. And we were joined with a stellar group of UC Berkeley graduate students, Drew Cameron, Catherine Duarte, and Ada Kwan, who continue to work with us. So our goals for today's Brown Bag Lecture are really to describe how COVID-19 has affected people in prisons thus far, to share some of the lessons learned from prison outbreaks that we've been working on over the past 6 months. And Steph at the end will introduce some opportunities for scholarship in the area of interest. So as of September 28th, things were quite bleak. About 135,000 cases of COVID among people who are incarcerated in US prisons, over 1,100 deaths. 26,000 cases among staff working in US prisons, and at least 63 deaths. And it's important to note that not all systems are publicly reporting, so these are certainly an undercount. Oops. This is San Quentin. You may have driven by. It's a California state prison near San Francisco and Berkeley, where over 50% of the population is older than age 50, and hundreds have other multiple COVID-19 risk factors. On May 30th, you may have heard that about 120 patients were moved by bus from an outbreak facility 6 hours south to San Quentin for their protection, since San Quentin had no cases at the time. Unfortunately, through a series of misjudgments and errors, by June 12th, San Quentin had 16 cases. And on the 13th, our team was asked to visit San Quentin to assess the situation for the state, and we issued an urgent set of recommendations based on that visit the next day. Our evaluation team's urgent findings were really to sound an alarm of a profoundly high risk of rapid COVID-19 transmission that could easily overwhelm the prison's healthcare services and local community hospitals. For example, we found antiquated facilities. Many were built at the turn of the last century. Extremely poor ventilation with open bars at the front of each cell, which you can see here. These cells are stacked one on top of another, but instead of having solid doors, they have bars. And that means that these units are basically like 750-person dorms with shared airspace. There was extreme overcrowding, 2 people assigned to most small cells that are about the size of a parking spot. And limited staff testing. There are no limitations on staff movement between housing units. We found the prison was inadequately staffed or trained to respond to the threat of a large outbreak. Staff were hampered by very delayed testing, sometimes 6-day turnaround times. Residents were terrified, and staff were really quite desperate for help. And sadly, over the coming days, as you have certainly heard and read about, our fears were realized. We witnessed a massive super spreader event at San Quentin. So here you can see in California at the time, there were 6 cases per 1,000 people. when we visited. Throughout the California prison system, there were about 48 cases per 1,000 people. But by early July, San Quentin had reached 427 cases per 1,000 residents, and that was just in July. That was just in 1 month. So at this point, about 2,240 people of around 3,200 have known infection. It's important to note that a lot of people have still refused to test, and as of yesterday, 27 residents have died. Our urgent recommendations from the San Quentin investigation and from other consultations we've really provided around the nation have now become 6 urgent lessons that we're going to share with you today. And the first lesson by far is decarcerate. Many people who are incarcerated in the US are in poor health. Many live in overcrowded, unsanitary environments. Over 170,000 incarcerated people in the US are older adults. And the rationale for public health focused decarceration is twofold. First, since the foundational principles of COVID-19 mitigation are to physically distance quarantine exposures and test to isolate cases, these actions basically can't be accomplished without space. Second, the goal for every community should be to minimize numbers in all congregate living environments because it decreases the risk of infection to those who are released, but it also increases the availability of limited health resources in the prisons and nearby hospitals to those who remain and end up getting infected. And our team has had a large number of opportunities to publish calls for decarceration early in the outbreak in anticipation of the coming plague. But sadly, while many jails have decarcerated rapidly and a few state prisons have done so as well, the prisons that have decarcerated have really been the exception to the norm, and many have essentially remained as overcrowded COVID factories. The second lesson is to understand and employ the ethical use of medical isolation and quarantine and not solitary confinement. So for those of you who don't know, and for those of you who do, this is a reminder. Solitary confinement goes by many different monikers, like the hole, colloquially, or administrative segregation, restrictive housing, isolated living. There's a lot. In it, people are housed approximately 22 hours a day, 7 days a week in a cell, roughly the size of a large bathroom. They eat, sleep, and toilet in this small space, and they have minimal access to showers and exercise, limited to no contact with loved ones, and rarely engage in any meaningful programming. So what does that have to do with COVID-19? Well, here's an account of someone tweeting from a US prison this month, describing his concerns about solitary confinement. He says, "Many were sent to solitary confinement for being sick with COVID-19. My friend finally got out after 45 days of being in a cage alone. I started counting how many words I spoke in a day," he told me. "One day I spoke only 6 words to myself." And this is where we hit a major roadblock in the fight to contain COVID-19 in prisons, because people who are exposed or infected obviously cannot be in close proximity to others or COVID-19 will spread. But fear of solitary confinement among incarcerated people based on years of the dangerous use of this practice deters patients from reporting symptoms, which leads to worsening of COVID-19 outbreaks. And frankly, and obviously, use of punitive isolation for someone who's sick also contravenes medical ethics. So as a first step to addressing this issue is really to clarify what is expected in the ethical use of quarantine and medical isolation in correctional facilities. And our team has really tried to work to clarify that. And the first step is to say it's even clear that many medical professionals are unclear about what these terms are. So first, quarantine is the practice of separating a person who is exposed to or is expected to have a contagious disease until it can be determined whether he or she will develop the disease. Basically, when COVID-19 status is unknown, people have to be separated from others. We don't know if they're at risk or if they pose a risk. And getting back to lesson 1, this practice requires room. Each facility has to have uninhabited cells. So patients in dorm settings or those in areas like what you saw at San Quentin with shared airspace can be temporarily housed alone pending testing results. In contrast, medical isolation is the practice of separating a person with a confirmed disease until they are no longer contagious. So people who have a confirmed diagnosis can actually be medically isolated together, alone or together, with patients who have a laboratory confirmed diagnosis of COVID-19 themselves. Basically, people who have symptoms but who have not yet tested positive or who refuse to test still need to be housed alone because we don't know if they could be infected by someone else or if they could infect someone else. Medical isolation also requires extra space. So in what ways should medical isolation and quarantine be the same as solitary confinement? This is a busy slide that basically is to say that the answer to that question is that the only commonality between solitary confinement and these medical practices is the physical separation from other people in a single cell for quarantine, or in a common area with other people who are infected in medical isolation. So we've been working with system to try to say what conditions should be present for the ethical use of quarantine or medical isolation. So here are some examples. Care and coordination and conditions should be overseen by medical staff, not custody. This isn't a housing arrangement. This is a medical intervention. It should be treated as a medical intervention. Patients should receive at least daily visits from healthcare and mental health staff. There should be clear communication about the expected duration of quarantine or isolation and the rationale for its continued use. They should have opportunities to go outside and exercise, at least for medical isolation. They should have enhanced access to television, tablets, radio, reading, anything that can make their separation psychologically more bearable. And obviously this is a terrifying time. They should have accessible means of communicating with loved ones. And so there are many proactive steps that correctional health and healthcare departments can take to ensure the ethical use of these healthcare interventions. And here are some examples, but most importantly, again, we have to make space. If COVID-19 has taught us anything, it's that correctional facilities cannot operate at or probably even close to 100% capacity. We need the room to respond to the demands of an infectious disease, to move people around without having to juggle a full or nearly full institution. It's really important to express gratitude. Asymptomatic people, especially young people who have no COVID risk factors, who've been exposed or who have mild symptoms, are doing a public service by reporting their symptoms to healthcare staff. They're keeping the community safe. We have to thank them, we have to incentivize them. And third, facilities and healthcare professionals need to be communicating, engaging so-called inmate or family advisory councils to identify ways to optimize communication, to understand their concerns. People who have been living in these facilities for the longest amount of time are the ones who know how to fix these problems and how to improve the situation for a better pandemic response. So lesson 3 and the rest of the lessons are much shorter. We have to optimize occupational health. You know, COVID-19 reminds us that our health is interconnected. Public health is truly prison health, and prison health is public health. Hundreds of thousands of staff enter and exit US jails and prisons every day. They bring infection back and forth from the community to work to the community. And many correctional staff are in very poor health themselves. They also work in unsanitary, overcrowded workplaces, the same places where people who are residents live. So we conducted a snowball sample of about 1,400 correctional staff members in the first month of the outbreak. And respondents were from 45 different states and Washington, DC. One officer told us, we no longer call ourselves essential. We say we're sacrificial. Another said, I'm my mother and father's ride for appointments and shopping. I need to be healthy. I know I signed up for this job, but none of us saw this coming. It's scary as hell. Too many people are not taking this seriously. There are a lot of examples of ways to shore up correctional occupational health during the COVID-19 pandemic. In many states, this is not happening. Some simple things: universal screening for symptoms and exposures before people enter the prison. No cost testing in hotspots, especially with widespread community transmission or in prisons with outbreaks. We need to organize staff and residents into cohorts that practice physical distancing from each other. We have to institute culture of health policies, things like paid sick leave, things like requiring people to stay home when they've been sick or exposed and paying them for it, not making them use their FMLA, for example. Providing access and training for PPE, hand sanitizers, soap, enforcing universal masking, and providing temporary staff housing and hoteling during outbreaks to basically protect families from facility outbreaks. Lesson 4 is to create a centralized outbreak response team. And this is really Sandy McCoy and Steph Bertozzi and David Sears really realized when they went to San Quentin how critical it was. The concept is that, you know, people who are working in the prisons in jails, the healthcare staff, they're there to take care of patients. They haven't necessarily been trained in how to deal with a worldwide pandemic and how to respond to it. And so they need an external resource that can come in and help them. For example, an environment of care lead, somebody who optimizes ventilation and sanitation and patient flow in the prison to mitigate spread of the infection throughout the facility, somebody who helps with cohorting staff, training them in PPE and infection control. A healthcare custody coordination lead who partners with custody to assess on a daily basis the housing of where residents are for medical isolation, for quarantine, what medical leadership needs next. A COVID-19 testing lead who coordinates testing of residents, healthcare staff, custody, who ensures paid testing, and really good rapid turnaround testing time. And an epidemiologist or an analyst who develops and reviews line listings of all active and resolved cases. The healthcare staff need to take care of patients, and they need somebody else to come in to help support the pandemic response. Lesson 5 is to clarify the rights of seriously ill patients who are incarcerated. This is really important for correctional healthcare professionals, but it's exceptionally important for community healthcare professionals. You know, at a minimum, patients should have the right to self-determination when they come to outside hospitals, or the ability to choose what medical interventions they want or do not want. They should have the right to name a medical proxy to make medical decisions in the event that they can't make those decisions for themselves, usually codified and protected in an advanced care plan, which correctional healthcare professionals should be ensuring that every patient has completed. But if they haven't, they should get one of these advanced care health plans when they are admitted to the hospital. And they should have the ability to say goodbye to loved ones at the end of their life, even if it's just through video or phone calls. And these are the rights of patients who are incarcerated, and these are the responsibility of our healthcare professionals in the community, who often don't know what the rights and recommendations are for the care of seriously ill patients who are transferred from prisons. And so we've done a lot of work to work with Department of Corrections in California with their legal team to make sure that the rights and responsibilities of patients and of healthcare staff in California are clearly delineated and communicated to healthcare professionals who've never been taking care of this many patients at once who are incarcerated. And the final lesson is the most important lesson, and it's number 6, which is to partner with residents and their loved ones to identify meeting solutions. I touched on this earlier already, but the COVID-19 pandemic has been a terrifying time for us all, but especially for people who are incarcerated and their family and loved ones on the outside who are absolutely worried sick about them. People who are incarcerated and their families have very important and very clear and very precise ideas and recommendations about how to build trust and partner together with staff, how to mitigate transmission risk, and how to fortify the facility and make it a safer place to be. And the systems that have done this have found more success. This is a Department of Corrections director from North Dakota, and I'm going to end with this. She said, why is a more humanistic approach to corrections important even now? She says, because North Dakota's prison residents are the Department of Corrections partners in the effort to keep our facilities safe. They're doing extra cleaning, maintaining social distancing as much as possible in a congregate situation, sharing their ideas on how to maintain a calm environment. And as a result, in a time of crisis like this, when there's heightened fear among us all, North Dakota's prison staff continues to receive letters of appreciation from residents, thanking them for keeping them well informed and being caring and patient during a very stressful time. They are true partners. And this is a fight that staff and residents are taking on together. And so now Steph is going to introduce some of the scholarship opportunities, and really just delighted that you're here with us today.
Thanks so much, Brie. I did put a note in the chat that it would be great for people to use the chat to ask questions or make comments. I encourage you to do that. If anybody wants to raise their hand and ask a question right now, we can also break, or we can come back at the end and have a broader discussion. I want to just provide a little tiny bit of context before I get into a couple of slides. And I'm extremely grateful to have been able to collaborate with Brie and her group at UCSF in this. The reason I got into this is because Brie and I both serve on the advisory board to the judge who oversees healthcare in the California State Prison System, along with our colleague at Berkeley, Professor Amy Lerman at the School of Public Policy. And it's a really, really rewarding engagement, because these are, amongst the most marginalized, least supported members of our society. And at the same time, because of the particular environment in California, where the health system in the prisons is overseen by a federal judge and a federal receiver, with extraordinary transparency and a desire to make things better for prisoners and their health, there's an opportunity to have an impact like is true in, I think, few other prison systems. There are a few that have become extremely enlightened because of prison leadership. Brie mentioned North Dakota. I think you probably include Colorado in that list. Oregon is probably well ahead of us, but California in the health space has a real opportunity. And so my part of finishing this up is really, like, I'm the ad to say, if any of you are interested in working with us in this space, please talk to us, because I think that there are extraordinary data available, there are extraordinary opportunities. If you go onto the websites with the California State Prison System health space, you'll see a degree of transparency that you won't see in other places. Not only will you see every day updated the COVID situation across all the prisons in California, but you can look at the dashboards for pretty much any medical condition you can think of. You can look at vaccination rates. You can look at all kinds of health indicators updated on a regular basis. There's a single electronic medical record system across the system. So this is really quite an opportunity to collaborate with the system and to do research that has potential significant impact. So I'm going to share my screen and just be a little bit more specific about a couple of those. So because I know there are different people with different sorts of interests on the line, I'm going to suggest a couple of different areas of potential collaboration. So one is clearly epidemiology. So in a prison, you have extensive data. You have data on exposure, on movement of both staff and prisoners, on who mixes with whom, on who lives with whom, who works with whom, who has recreation time with whom, which people eat together and at what times, who shares showers, toilets, what is the cleaning and disinfecting protocols, use of PPE. We have extensive data on dates and evolution of symptoms and test results for the entire population, 96,000 people now approximately across the prison system. And we have the ability to model spread and better understand the determinants of that spread. And just to give you an example, imagine a dorm. Now, I think many of you who imagine a prison might imagine, if you haven't spent time in prisons, you imagine something like San Quentin. Well, it turns out that San Quentin, the picture that Brie showed you, is very different, except for San Quentin and Folsom, than what you see in the rest of the system. Most prisoners in the system are either housed in cells, which are not in these massive open cell blocks with bars on the walls into an atrium with 750 or 800 people in the room. They're on hallways with cells on both sides, and very commonly those cells have walls and doors, not bars. But many people in the prison, and I think most people don't realize this, are in dorms, like the one that I've just drawn a sketch on the screen. And this is close to 200 people in a dorm, which is not uncommon in the system. And you can imagine that what they have done initially in response to COVID was that they clustered the bunks. So think of each of this cluster of this is 4 bunks or 8 people. They put people into 8-person pods and separated those pods from the next pod by 6 feet, because the CDC had said, keep people 6 feet apart. And they told people that when they were circulating, they needed to wear masks, but when they were in their pod, as if they were in their house, they didn't need to. Well, of course, this doesn't take sufficiently into account that even though droplet transmission may be significantly less beyond 6 feet, if you're spending 20 hours a day in the same room with 200 other people, a much greater proportion of transmission is likely to be aerosols. And so what we have the ability to do right now is to know that the first case in this dorm was in bunk N6, and the second case was in bunk M15 or whatever. But what we're about to do is go out to 4 prisons that have had significant outbreaks, go into the dorm and actually be able to show that the first the first one was here. The second one was here in the same pod. So was the third, but then the fourth was 2 pods away. And the fifth was next to that one. And the sixth was over across the room. And then quickly there was a huge outbreak in that dorm. But the ability to track over time who was infected when enables us to look much more carefully at the epidemiology of spread and the relative importance potentially of droplet spread versus aerosol spread. For example, we have many different sorts of housing facilities where people do or don't share toilets and dorms. And so I think it'll be very interesting to look at the heterogeneity across the system and model the type of spread that we have in different sorts of housing environments. And you can imagine a dorm like this. You can also imagine 50 cells on a corridor and look at the spread from cell to cell. You can imagine a situation like San Quentin where you have spread, how much harder was it to spread 2 levels down in those tiers versus the next level down versus to the neighboring cell, et cetera. And the other thing we're going to collect as we go to these housing units is the physical dimensions, both 2-dimensionally, the way I've represented here, but also 3-dimensionally in terms of volume, as well as ventilation and air exchange. And to get at least a preliminary indication of air exchange, we're going to be doing CO2 measurements in these housing environments, because previous work with TB has looked at how CO2 concentrations are a nice indication of the amount that the air is being rebreathed by the people inside that space. And so that's an indirect measure of the degree to which there's air exchange to the outside world. Now, that doesn't tell you anything about filtration, because of course the CO2 goes through the filters, but we can also look at the degree to which there's recirculation through filters versus air exchange. So in addition to that, you've got a population of people who have far more complete testing than they do in the community. So we can think about the clinical evolution and the correlates thereof with knowing much more about asymptomatic and mildly symptomatic cases than we do in the community. We have direct observation of the evolution of those symptoms, including for large populations who are in quarantine or under medical observation for whatever reason. We have a system-wide electronic medical records with full population-wide documentation of underlying comorbid conditions. And we have the ability to track longer-term sequelae of both asymptomatic and symptomatic cases within the same healthcare system, even if people move from one prison to another. And I learned yesterday that we're now down below 100,000, but it's still a very large population. And that's only the prison system. That's not counting, obviously, our county jails in California. Secondly, we can think about using the data to think about prevention effectiveness of different public health measures. So within the system, there's been great degree of heterogeneity with respect to when certain things were implemented, adherence to them. So I say here, for example, adherence to cohorting. What do we mean by that? Ideally, if you have a prison of 3,500 people, you don't want it to feel like a dorm of 3,500 people. Ideally, if you were running that prison in the time of COVID, you wouldn't want to break that prison of 3,500 into, let's say, 10 prisons of 350. That way, if there's an outbreak in one of those 350 size prisons, it may pose a much greater danger within that cohort, but it won't cross over to other cohorts. Now, why would it cross over to other cohorts? Well, because prisoners work in a common kitchen, or they go to a common workplace, or they clean outside of their cohort, or most importantly, staff work in more than one cohort. So the idea of cohorting is to effectively break the prison down into smaller units. And when people need to cross over, make sure that there's testing, enhanced PPE, et cetera, to prevent that. So all that kind of stuff, how much physical distancing is there? What kind of PPE utilization is there? Very few places can you imagine having camera footage, which you can use to look at PPE utilization. You can look at the reduction of size of housing units, the degree to which yard time and eating time were disaggregated into, every cell block going to the yard separately in sequence rather than going together. Same thing with cafeteria eating times. You can look at different testing frequencies, quarantine policies. When there's an exposed cell block, is everybody quarantined individually, or have they been quarantined together in dorm-like settings? The other interesting thing is that we've now got about 10% of the population has already recovered from COVID-19. And today, unintentionally, because there has been no intentional movement of those residents, they're heterogeneously distributed. And so we can learn about the degree to which the presence of previously exposed people in a community, in a housing unit or whatever, will affect HIV, you can see where I come from, will affect SARS-CoV-2 transmission in those populations. Now, there's also the possibility of starting to strategically use the distribution of people who are recovered to reduce risk. And for example, discussions of if you have an entire dorm of 40 people infected, would you rather keep those 40 previously infected people together in one dorm, or would you rather take 2 dorms of 40 and split them up 50-50, such that there are now 20 susceptible people in each dorm rather than 40 susceptible people in one and none in the other? And then of course, there's all the issues about, will people become susceptible again as immunity wanes? And on Friday, I reviewed a manuscript from China suggesting that one cohort of patients has significantly increased severity on second infection, which was extremely disturbing. But that's something that the prison is very concerned about. So, and that's what I just said. So this is now my pet issue. I don't think there's really much opportunity here, but there's a lot of interest in a number of people that I've been working with suggesting that live attenuated vaccines stimulate innate immune pathways and may protect against infection or severity of infection by other pathogens. And there's very interesting data from Russia on the use of oral polio vaccine to prevent infection with influenza. And there's been a number of other studies looking at live vaccines, in particular measles in Africa, and the beneficial effects on populations because of that. Well, there is heterogeneous use of live vaccines. There have been mumps outbreaks, which has led to use of MMR among prisoners. And there's also potentially the opportunity to vaccinate with both inactivated and flu-mist live attenuated influenza vaccines and look at the potential protective effect. As I say, I'm not super optimistic that the system's going to decide to do that, but if they did, we could certainly help them look at the impact. Last thing I want to mention is the more social science aspects of this. In evaluating the different settings where epidemics have raged in the California prisons, you can see that it makes a huge difference what the relationship is between custody staff and residents in the prison. And Brie showed you the quote from North Dakota. She didn't mention that a huge part of her work involves working with the prison system in Norway and helping American prisons and prison staff in particular, custody staff in particular, understand how Norway has transformed the relationship between custody and residents in a way that is much better for both of them. And but the perception that we have, certainly in this country, is that custody staff have more reason to fear residents than the other way around. Of course, in the time of COVID, that's very different, because we've had very few officers die of assault in the last decade. We've had 9 who've died so far of COVID, and those are only the ones that the system knows about, because of course, some people die in the community. It's not like a prisoner where you know that somebody's died. You can have people who go out on medical leave and you don't know exactly what has happened in the population of custody. So the importance of developing a strong custody resident relationship is key. And I think there are real opportunities for this, especially in collaboration with Brie's work in Amend. And I think we have an opportunity here because of COVID to reinforce this idea that there is a shared interest in both health and safety between custody and residents, which in the case of COVID includes a shared interest in decarceration. I also think that we need many more people to visit our prisons, because you can't go to a skilled nursing facility with 2,400 people that is a prison, and you can't go to a prison where 80-year-old men are shuffling with their walkers across the yard, and imagine that we're doing the right thing by keeping those people incarcerated today in the middle of a pandemic where we know, as Brie has shown you from San Quentin, that we have explosive spread within those environments. I mean, San Quentin is disproportionately older and sicker, as Brie mentioned, but there are other prisons that are essentially skilled nursing facilities. The California Medical Facility has about 2,400 people in it who need much higher level of support for their health conditions. And with that, I'll just mention that if you're interested in modeling using our available data, please get in touch. We have this new study that I mentioned where we're going out and collecting additional data to complement the data that the system already has. We have permission, assuming everything is properly signed off, for modelers at UCSF and at Berkeley to use those data. And if you see other areas in which you'd like to get involved, students or faculty, please also get in touch. We can consider expanding the scope of our work. We can help to put you in touch with the right people so that you can have your own relationship. And we can also look at opportunities for administrative supplements onto existing federal grants, especially, or some of the work that we're doing with support from the state to fund things that you may think of and that you could do with the data that are available. So with that, I'll leave you just with emails, but we'd love to hear questions and comments from all of you.
There's one great question in the chat that I was just responding to, and also I want to invite Ada or Catherine if you're here, or Drew, or Sandra, Steph, to respond as well. But there's a question about how can this research be done, not just for the sake of research, but to actually change practice and policy. And that is, in my opinion, that is the only reason that anybody should be doing any of this research at all in prisons right now. We need to bend the morbidity and mortality curve immediately. And what we're doing right now is we're trying to bend that curve with kind of good faith effort, but not with data. So we need data to make sure that we're making the right choices at the right time that will improve the health and save the lives of as many people as possible.
Jack asked about testing at San Quentin, which right now is one of the lowest priority places for testing because they have just a handful of active cases. And so San Quentin, just so that you're aware, is 4 ginormous cell blocks, 750, 800 people, in these built in the mid-1800s that look just like Alcatraz if you've been there. And then they also have a newer section which are dorms. So what happened in the outbreak is that the prisoners that were transferred into San Quentin were transferred into one of these large cell blocks. And that quickly spread across all 4 of the cell blocks. They've been relatively spared in the dorms. So there is still an issue of people potentially becoming infected in the dorms. There's not much risk of them becoming infected in the cell blocks because everybody's been infected. I mean, I'm exaggerating only a tiny bit. But in general, across the system, there are issues of testing prisoners or residents, but even more importantly, there's an issue of testing the staff, because overwhelmingly, introduction of the virus into the prison comes through staff. And so the question of all the things that Brie mentioned about making sure that you're detecting people who are symptomatic and making sure they stay home and don't come to work and all of that stuff is extremely important. But we also need testing to make sure that we identify people who are pre-symptomatic or asymptomatic. And we've been pushing hard to get them to start doing pooled testing so they can test more frequently and rapidly eliminate people who are negative, but have early identification of positives. And also, Jack, thanks for, I didn't know Art was involved in the crossover effects of vaccines, but I'll definitely reach out to him. Anybody want to raise their hand? It's uncharacteristically quiet for Berkeley. Let me mention one thing just because I know some of my more...
We're really nice.
Some of my more vocal colleagues, I've done, both of us, lots of us, and Sandy and others have also done lots of interviews. One of the things that I've been criticized about is the way that I've spoken about decarceration. Because as you can imagine, the need to decarcerate for COVID comes on top of the need to decarcerate because of mass incarceration in this country. And one of the things that I have done in some of these discussions has been to suggest that even if people need to serve the rest of their sentence so that they will have to come back to prison, or even if they need to continue to be restricted in their mobility with ankle bracelets or whatever, that the immediate public health need is to get people out of the prison. so that they serve their time later, they serve their time now in a different way, or they don't serve more of their time. All of those things would accomplish my goal of trying to slow transmission within the prison. That's been heavily criticized as supporting alternative forms of incarceration like ankle bracelets, et cetera, and supporting furloughs, meaning a temporary release instead of commutation of sentences. So it's been one of the things that I've been wrestling with, and I know that some of you are interested in those issues. So if you're interested in engaging, that would be great.
We have a question, Steph, from Betsy Noth. What is the most critical gap in evidence based in the data? Sorry, I didn't say that very well, but what's the most critical gap you have in evidence-based data? And then there's a question from Jack as well about what models do you suggest would be the optimal testing frequency in prison settings?
Well, I'd love to have some of our collaborators who are here. I'm looking at Drew.
Sandy.
I'm looking at Sandy. Who else is there?
Ada's there.
So anybody else want to answer the question about what you think of as a critical data gap? Go ahead, Sandy.
Yeah, so thank you guys for a fantastic presentation, and I have also been so proud to be part of this work. I think one of the areas that I have found to be the most interesting and also offers the most opportunities for scholarship, building on what Steph and Brie have presented, is just that we engaged in this work at a time with a rapidly evolving scientific knowledge about SARS-CoV-2. And, you know, at the time we were visiting prisons, we were seeing, I think, what we have seen in the media dubbed as sort of hygiene theater, just like sort of an overemphasis on sanitation of surfaces, for example, and not yet quite a recognition of the potential for aerosol or droplet spread over many feet or yards or even in entire airspaces like a cell block. And so I think the work that is being proposed in Steph's half of the talk is just really important, because as we have sort of renewed knowledge about the potential for aerosol spread, we really need to know how to keep prisoners and staff safe in those environments where the contact rates are just so high that a catastrophic outbreak event can happen quite rapidly, far more rapidly than can happen to us in the community.
Just to build on that, you know, I didn't realize how catastrophically long the delay times were in getting test results back. Imagine a situation in which you're trying to stamp out an epidemic, but you don't get test results back until after a person is no longer infectious. The whole idea of testing and knowing who's infectious and being able to protect the rest of the population from those people. So I think that we're also learning a lot about the failures in the system. I loved Bill Gates's suggestion that any test results that come back after 48 hours shouldn't be compensated. Because what we have is testing companies, and unfortunately the prison system relies on commercial testing companies who take in far more than they have capacity to process in a timely manner, and so they become useless. Drew, do you want to say anything else about the physical space? I think that
thanks, Steph. I would let others speak more to the physical space. I think Brie brought up a really interesting point. I hope the political cover that's needed to take some of the actions around incarceration are a real critical gap, and there's a lot of opportunity to look at evidence of cost effectiveness of decarceration or depopulation of the prison systems in order not only to slow the spread of future outbreaks, but to also relieve a lot of pressure on the system itself to deal with those outbreaks when they do occur.
And I can't help but call out, Drew started this work, which is just a little while ago, as a doctoral student, and then he's about to be an assistant professor at Yale. So congratulations, Drew, and I really hope that we can continue to work together. Right now he's in Alaska, which is why the internet isn't so great. But he's virtually moving to New Haven.
Ada's on here too, and Ada's now leading the effort on behalf of all of us to collect the primary data that's needed to really supplement the administrative data. Ada, I don't know if you have any thoughts about some of the questions that you're most looking forward to being able to answer.
Yeah, thanks Brie and Steph. Great presentation. It's been wonderful working with this team throughout the summer. Some of the things I think are critical gaps that in the evidence is definitely with regard to physical space. These prisons in the system have such different and varied structures and opportunities for ventilation if they exist. And so I agree with Drew and Brie and Steph that those are really important data elements to collect to inform the decisions that are occurring. I also think that there's a very interesting element of related to leadership and how communication and information travels throughout these systems, all the way from the top level through to the cell level and the dorm level. And there are different information and communication channels that can enable a lot more prevention to occur and a lot more mitigation efforts to be adopted, and others that may inhibit it. So those are very interesting organizational elements also.
And Ada also finished her PhD this summer and is now a postdoc in Brie's group at Amend at UCSF, which is why she gets to lead this new data collection effort. And it's been fabulous working with both of them and with Catherine Duarte on this project. One of the things that, what Ada just mentioned about the physical space, what's striking when you walk into one of the cell blocks at San Quentin and look up, you might think that you were in a Hyatt hotel. If you've been in a Hyatt hotel, that giant interior atrium with circles of cells, circles of hotel rooms around the atrium. There's a huge difference between it, of course. One is that instead of doors and walls, they're bars. But the other is that unlike a Hyatt hotel where the atrium's in the middle and the rooms are on the outside and have windows, in the case of San Quentin and Folsom, the cells are in the middle. So the atrium is around the cells. So the cells ventilate onto the atrium, not to the outside. So you can't get that kind of cross ventilation that you can get in a situation where you have the cells on the outside wall. I recently watched Escape from Alcatraz. And if you want a good sense of what it looks like, watch that movie, because it's exactly that kind of cell that we were dealing with at San Quentin. And the tragic thing is that now there are over 500 people infected at Folsom, which is the other prison. So the three prisons from that period in California are Alcatraz, San Quentin, and Folsom. And Folsom right now has a raging epidemic, not growing quite as fast as San Quentin because they poured all kinds of resources into trying to slow it, but it's not successfully stopping it.
We're getting towards the end, and I'd just love to say, just to make sure that I have said it, what we're seeing in the prisons and the jails to a lesser extent, but certainly true as well, with anywhere between 85 and 90 of the largest clusters in the US and therefore in the world of COVID-19 kind of exploding in our prisons in the US, what we're seeing is a reminder. It's like a clarion call for a moment of national reckoning on our extraordinary reliance and over-reliance on mass incarceration. If there were ever a moment to look at the way that race and racial violence and racism and educational injustice and poor health and health disparities intersect, it's now, obviously, in many systems throughout our nation, but one that is all too easy for many Americans to forget is the prison and jail system. And with 85 of the 100 largest clusters or something like that, I'm not sure what it is exactly today, being in jails and prisons, we're not going to bend the curve of the COVID-19 pandemic until we address it in prisons and jails. And we're not going to address it in prisons and jails until we tackle mass incarceration. So I think that this is a real moment for an extraordinary amount of introspection and political activism. And our hope at Amend and with our partnership with UC Berkeley is that that political activism will have the epidemiologic and scientific tools it needs to get some traction where it hasn't in the past. And that's really our goal. That's really our effort, is to help to fuel a national conversation about mass incarceration. So we hope you'll join us. We would love to work with you guys. And more than anything, just so happy that you all called in and listened to what we had to say. But there's an extraordinary amount of work to be done, and every single one of you has tools that are desperately needed in this fight.
Thank you, Brie. And within the school, our JMP students and White Coats for Black Lives have chosen this issue of decarceration as a priority issue for them. So I encourage you to engage with them. I don't know if any of them are on the line today, but so thank you, Brie, for coming over. And I just also wanted to share Brie with our community because I think she's extraordinary, and I want her to be able to collaborate more with more of us because the program that she's got is just so inspiring. I mean, we've only talked about COVID today, but the stuff that she's doing with Norway will make you cry when you see what they're accomplishing. So thank you for having us. Thank you, Brie, for joining us. Thank you, Sandy and Ada and Catherine and Drew for working with us, and all of you for attending.
Thank you so much, Brie and Steph. We really appreciate your time and sharing your really important work. So thank you, and have a good day, everyone.
Thanks, everybody. Stay safe.
Bye-bye.